Unfortunately, what happens is when a patient walks into our clinic, we fail to recognize the patient as a toto. So it happens that if I am a vascular surgeon, I might just look at the pulse. If it is coming to a physician, he might just look at the sugars. What we many a times miss to see is the entire picture of the patient, and that is what is a critical problem which we all should make sure that it doesn't happen. So when I'm talking about a peripheral arterial disease because of diabetes, you can see that it can form clots from anywhere in our upper limbs, our abdominal vessels, femoral vessels, leg. It can form clots or it can form calcium plaques, and eventually that will cause decreased blood supply to whichever part it is supplying. Another problem is many of these diabetic patients end up having chronic kidney disease because any end organ damage can occur. So a combination of diabetes, PAD and CKD is a typical combination which we are nowadays seeing in many of our patients. Combined with that is the neuropathy, which the first speaker has very elaborately explained. So when we are looking at the limbs in a diabetic patients, these all complications are very likely. Now, when we see about where is the location of the disease as compared to a non-diabetic patients versus a diabetic patients, we see that they have maximum disease which is there below the knee. So it affects more the smaller vessels. So there is microangiopathy and macroangiopathy. In macroangiopathy, it is the cruder vessels which are predominantly involved. Now, this was a very interesting study which was done in 2017, that every 20 seconds, someone with diabetes undergoes an amputation. And this figure of 20 is now coming down to 16, and the data will be surely published. So even in this 20 minutes talk, every 16 seconds, somebody is losing some part of his body. Unfortunately, because the diabetes don't have some kind of, they have some kind of neuropathy, so they will not come to us with a claudication pain or a pain. So they will usually come to us with ulcer and necrosis. And because of this late referral, we lose the time which we would use it to revascularize and save that organ. So as vascular, for us, time is tissue. The delay in presentation and the delay in referral speaks a lot about the treatment options and the success from the treatment. And it has been seen that more than 50% of patients with critical limb ischemia have undergone major amputation but never had the opportunity to get a vascular workup. So 85% of these amputations are preceded by foot ulcer. So the aim is, if a patient walks into any one of us, whether I am a nephrologist, cardiologist, physician, endocrinologist, the way we check pulse and BP for all the patients, we need to get into the habit of checking the pulses of the leg and have a look at their feet. If we get it as a part of a system, as a complete clinical examination, then this late referral related problems can be avoided. So basically, the reason I have put is, it is not that diabetes has come overnight. It has been there since ancient ages, and the wound healing has also always occurred. But what is important is, after such a bad wound, patient ends with having only losing part of his foot, that is a transmetatarsal amputation or a below knee amputation, or he or she ends up losing his life. So these are some evidence which say that major amputation profoundly increases the mortality of a patient with a diabetic foot infection. So a 5-year mortality of a patient with diabetes who has undergone an amputation is nearly around 50 to 62%. So that means we have to look into early wound care and ischemia management to prevent diabetic foot infections, and not only DFIs, also the mortality of these patients. Now, this was a very interesting data which had come, that we all are very scared of cancer, and cancer will cause death. But this paper said that lower limb amputation has 60 to 62% chance of mortality in the next 5 years. So only 22% of these cancers were matching to that of a lower limb amputation. So this was a study which was done by Dr. David Armstrong, in which he says that the 5-year mortality and the direct cost of care of these people with diabetic foot complication is comparable to cancer. So it is very important for us that we all know that cancer is there and it is a deadly disease, but diabetic foot infection is far more deadlier. It is a very silent killer, and if we pick it up earlier, we are able to help patients in a better way. So coming to how do we manage it? We all know it's an epidemic which has happened, and how do we manage it? Coming to management is patients will have ischemic ulcers because of decreased blood flow, or they can have a combination of decreased sensation, neuropathic plus ischemic ulcers. So they will usually present with rest pains or tissue loss. There will be the abnormality in the pulses, and there will be abnormality in their ankle brachial index, which we usually do for all the patients that walk into our clinic. We do see what is the peripheral oxygen saturation, TCPO2, and as a routine, because of these patients will have some issues with the kidney, their creats will be borderline or high, so we don't subject them to any of the contrast related imaging. We do non-contrast MR angios with time of flight sequence. So this is a very good study which gives us an entire roadmap of the vasculature. Putting a diabetic patient pushing through a CT angio causing contrast related issues, and also the quality of the image is not proper because of the calcium. We will not get to know how much or where is the area of stenosis. So this is what is I want to emphasize. If we offer all patients with lower limb revascularization who need lower limb revascularization and diabetic, we offer them non-contrast MRIs. And after that, once we get those pictures, what we do is we revascularize that leg or foot depending upon the angiosomes. These are the 6 angiosomes which are there for a normal foot, but unfortunately we don't know what anatomy books, the wound don't read an anatomy book, so we also offer them indirect revascularization using indirect angiosomes. To make it an interactive session and to get an audience participation, so I am going to discuss few cases in which Dr. Mustafa will also be helping us with some of the cases. Can you give him a mic? It will be great. So this is a 70-year gentleman who is diabetic, hypertensive, has a cardiac history. He comes to us with a wet gangrene in his right 4th toe with rest pain. So what we follow is this Y5 classification: wound, ischemia, and infection status. We also do what is said to be as a pedal acceleration time. Pedal acceleration time helps us to find out how good is the blood flow happening to the foot. So that gives us a real-time imaging of whatever is the supply happening to the foot. After an MR angio, we are seeing that this part of the aorta is narrowed in this area, iliac segment. There is no blood flow which is seen in the thigh, that is the area of the femoral. P3 segment or isolated popliteal segment is seen, and then there is some tibial disease. So basically the reason for his wound not healing is he doesn't have blood which is going into his right leg. So what we do is an hybrid approach. For the iliacs, we do an angioplasty and femoropopliteal bypass. So this is the normal femoral vein, and here the bluish structure is a vein, the patient's own great saphenous vein, which is harvested from the leg, and one anastomosis is to the femoral artery, another anastomosis is to the popliteal artery. After that, the infected toes which are there are removed, but we are not very radical in the first part of the debridement because we have to give time for the tissues to heal, for the blood to reach these areas of the wound. And gradually, over weeks with dressing, some skin substitutes, the wound heals and we are able to give the patient a biomechanically functional foot. Now, biomechanically functional foot is very important. I will not end up removing the toe and give him some few toes, and eventually that will take a brunt of the load of the patient and end up with a second ulcer. So that is very important. What we need to give him is a biomechanically functional foot. Dr. Mustafa will be describing about the second patient which we treated.
Thank you. Good morning, everyone. So this is a case of a 65-year-old male. He presented with chronic diabetes mellitus and CML, chronic myeloid leukemia. So he had cancer on the left coast, for which he had procedure done outside hospital. So MRI angiogram was done. So, as protocol, the MRI angiogram was done and it showed tibial disease. White staging and PAT was done. It showed a below tibial disease of TP trunk and tibial vessels. So, on the angiogram, we took a femoral axis, the CFA axis, and the angiogram showed the SFA, the superficial femoral artery, was okay, the SFA was good. The popliteal was also fine. Behind the popliteal was fine, even the and then below the tibials were the cause of the disease. It was single vessel outflow, peroneal, and then it's going into the DPA. There was no PTA in the ATA. So we angioplasty the DCP, special drug vessels, which increase the patency of the vessels. Also, we needed extra vessels, but we tried to candidate and open the PTA, posterior artery, but it was not possible from the antegrade axis. So we took an axis in the foot of the active and from there we crossed the occlusion, PTA occlusion, and angioplasty the whole vessel. The end result was a good revascularization of the arch, and it gave us better treatment options for the patient. The arch was almost revascularized.
So after that, since that fourth toe was amputated outside, there was a wound which again needed some debridement. So we debrided it, but again, as I said, we don't do or remove everything. There is something like line of demarcation we wait. Like body is trying to reach some vessels, some tissue, give it some time, because there is where these indirect angiosomes are going to act. And eventually we give a biomechanical functional foot after doing a good TMA and covering it with a skin graft. Now a similar patient, diabetic, post CABG, on dialysis, we did pedal artery revascularization, but we also used minimum of contrast even though he was on dialysis, but that doesn't mean that we push him through contrast. So wherever feasible, we use CO2 as a contrast agent, and we aim to revascularize the pedal arch. So the reason why I brought up this case is fungal infection is known in diabetes, but fungal infections for the wounds is also a very common thing which goes unnoticed. It is sometimes what you will see only what your mind knows. So if your wounds are not healing, irrespective of revascularization, please check for the fungal cultures. And the reason is, even if you take a wound swab for culture, if you don't tell the labs that you're looking for fungal cultures, they will not do it. Or if they're doing it, they will not intimate it to you that it has been done. So it's important to know that fungal infection comes in the wound, and this patient required both IV antifungals, and in VAC we instilled antifungal medicines, and that eventually helped that wound to heal. Another case which Dr. Mustafa will enlighten us about.
This is one more case. 60-year-old male, again diabetes, hypertensive, and this time he was also having disabling low lymph claudication. So on examination, we found low lymph payment pulses were there, but they were not that they were feeble. ABI was done, and APPG of dose was taken, which had happened bilaterally. Imaging was done, which showed heavily calcified vessels. So in the heavily calcified vessels, the amount of luminal gain that we get with conventional OVAs is not that great. So for that reason, newer advances the IVL, that is intravascular lithotripsy, which helps in getting a better luminal gain post angioplasty. it gives out shock waves with pulses, which helps in disrupting the calcium and helps in getting a better luminity post angioplasty. So in this, we also did an IVIS, but the video is not working. So post angioplasty with IVL, we did a angiogram and an IVIS, and it gave us a better luminal gain. Since it was in the at the bifurcation of the artery, so we did a kissing stent later on, bilaterally, and post that we got good pulses in the medium bilaterally.
So, but it doesn't stop there. We do best for the patient in the best interest, but since the patient is troubled, he or she rather follows all the advice. Later on, once the ulcer has healed, is the second problem which starts. The ulcer has healed, patient doesn't comply with a footwear, whatever we said. So he has bought the footwear, but since he is neuropathic, there has been a nail in it which has gone unnoticed. And this gentleman actually, he came, if you have a closer look, there are cobwebs in this footwear. He said, madam, it was such a costly footwear. I used to keep it in a plastic bag in the cupboard. Only when I'm coming to visit you, I am wearing it. That defies the purpose of having a diabetic footwear. It has to be worn whenever the patient is walking, standing, sitting, going to the washroom, or whatever it is doing. So this is what is lacking. We do, but after what we have done, lot of money has gone, lot of hard work from us, from the patient has gone. But if this lacks, then they come to us with footwears, and these are real-time patients who have spent lakhs of rupees on intervention. But this simple thing which they didn't do it post-procedure, and then they again land up with the same issues. So what we do is we are all aware of CPR. So what we do is CPR for feet. So it's a very thing, any patient who walks in, whether diabetic, not diabetic, has come for fistula, has come for laser, we make sure we do CPR for the feet. We check their feet. If they are prone to having any issues, we protect it by giving them appropriate offloading footwear. And whenever needed, if we think that we don't have the facilities or we are not the right person to treat, we refer them to the appropriate person. Another issue which I would like to highlight is we come across lot of hurdles because of local faith, and unfortunately because data is rampantly available, people publish it. And especially the IT person, he came to me, madam, should I use this on my wound? There is studies which are saying, evidence-based, as you keep on talking, there is evidence that this will allow my wound to heal. Now the wound was like this. So all of these are local faiths, and at times I find it is difficult to explain an IT or a learned person versus a normal person who has come from a mediocre background, because then they don't follow advice, they follow more the Google doctor, and it becomes difficult. So once I told that no, this is gangrene and there is clot which is there, then that was a problem, that was a thrombectomy done. So what is the take home message is, as we check BP, we should check the pulses, good glycemic control, weight control, walking, and whenever required, we treat the artery. Either we do an open revascularization or an endovascular revascularization. Another thing is what I keep on telling all the patients is realistic expectations. What they have come to us and what we are going to deliver to them is very important. At the same time, the patient should have a good social support system, because it is not that I'm giving dolo and your temperature is going to come down. It's not that instant effect which is happening. The treatment is to stagger over next few weeks or months. So realistic expectations and this support system are very important for any wounds to heal. Now this is the team which I'm fortunate to be working in Care Hospital, but we are actually only the poster boys or girls. The main person of this team is our patient, who have been very kind, considerate in following whatever advice we are giving and getting the appropriate results. And these people are the actual pillars. These are our wound warriors. Thank you.
Thank you, ma'am. You have presented everything so beautifully. Madam has put down every point in a very beautiful manner, in a systematic manner that everybody can understand. That everybody can understand. It was a very beautiful presentation. Like everybody of us, for the students here, everybody of us are hooked to Wi-Fi. We cannot live without Wi-Fi, right? In a similar manner, whenever a patient comes to you with a, madam has already put this forward, with a wound, always look at Wi-Fi. That is wound, foot infection, and ischemia. If you have got a wound, then there is a grading system of 0 to 3. Foot infection, there is a grading system of 0 to 3. Ischemia, there is a grading system of 0 to 3. Any wound cannot heal if there is no vascular supply. So that is why vascular intervention, blood supply to the foot is essential for the wound to heal. So all these three parameters has to be kept in mind, especially for the students. Wi-Fi to be taken care of, and rather than sending the, once the patient comes to you, rather than sending the patient to multiple duplay and all, when there is a vascular issue, it is financially very taxing. So as madam has told, time of flight MRI or serum creatinine is well within a normal range. CT angio is preferred rather than sending the patient to multiple duplay, arterial duplay. Thank you.
Hello, one question is there. At a general surgery level, normally we see when we do an application of a toe or a grade or something, after a few days the adjacent toe also get devascularized. And then we remove that also. And after a few days the other toe also get affected. So how to prevent this by doing the debridement of the initial debridement, so that the adjacent toe doesn't lose the vascularity, because all the small caliper vessels are already compromised. There is no blood supply. So while doing the debridement, any special precautions should be taken at the general surgery level.
Yeah. So at the general surgery level, it starts with examining the patient. We make sure that dorsalis pedis, posterior tibial artery are clinically palpable to us. If we feel that it is not palpable to us, or if it is feeble as compared to other leg, or if there is any doubt, get an imaging done. Not necessary at general surgery level, you have to go directly for a non-contrast MRA. You can get a basic Doppler done. If the Doppler says it is normal, and still if you feel that while doing your debridement, you are not getting this, then what we follow is we keep slicing it tissue by tissue. So once I cut this part, I feel that this is dead necrotic, then I advance that cut. If that is having a brisk bleeding, then the chances of it are better that it will heal and it will not spread. But if there is microangiopathy, then whatever you do, today you do a debridement, next day you open the dressing, it is becoming dusky, dark, and it is progressive. That means that it is either not getting, again we go to Wi-Fi. Either there is any foot infection, some bacteria which are more stronger, you need to step up your antibiotics, or there is ischemia. So if there is ischemia, and you, even if you have good pulses, then we have certain things like we give them prostaglandins, or we give them, nowadays we have topical oxygen therapies, which we do it so that there is good perfusion which is happening locally. So as a general surgeon, the main rule is you keep slicing it, and if you feel ki no, it is going much way beyond from what it is, close the wound, get scans done, then again CPR, refer it to the right person who can manage it in a better way before the patient loses the limb.
Thank you. One more question is there, madam. Usually we see that earlier we used to give insulin infiltration locally for the wound area. Insulin injections were infiltrated. So what is the effectiveness of this? Like, even still now, this has been practiced in many of the medical colleges, hospitals, where we inject insulin injections around the wound for a better wound healing and wound contraction.
I am not aware about insulin injections in the wound. If anybody from the audience can highlight.
Short-acting insulins are being used for that.
I don't think technically, from whatever I have learnt in wound care, giving anything like insulin would help. It is, if it has to be given, it has to be given systemically.
One last question is that, madam, those individuals with diabetic foot and diabetic grade 1 now, if they have coexisting chronic venous insufficiency.
Yes.
So how to approach these types of issues? Whether we should focus on the venous part of the arterial, whatever arterial insufficiency.
Yeah, actually that is a different talk in which I talk about venous arterial with diabetes. So in that, it depends the location of the ulcer. If the location of the ulcer is in the venous territory and it is an infected ulcer, then what we do is we take care of the ulcer by locally using whatever local debridement. We give compression, and at the same time we revascularize the patient, because if it is a significant arteriopathy, ABI is less than 0.5, then I cannot even give crepe bandage because that will cause more of ischemia. But for a venous edema to settle down, you need some compression. At times, we put them on lymphedema pumps, which give sequential compression, take care of the venous edema, and reconstruct the arterial system in whichever way is possible. So, it is like whether the chicken came first or the egg came first. We don't know, but we have to treat both of them simultaneously.
I'm also interested,
Yes.
and your presentation was very good. I just wanted to highlight for the audience a few of the points you have mentioned. One thing is that team is the essential part of food management. No doctor who has food has great needs, irrespective of the specialty, he can't manage every aspect. And referral should be there among different specialties at the earliest possible. As a general surgeon, I am managing, or as a physician doctor is managing. Usually, it is reference to refer. Many doctors will, they can do anything. It is not that like we have to put, at times we need a ortho, at other times we need a plastic surgeon, at times we need vascular. So, earliest referral to the concerned specialist is important for the salvage. And regarding, we mentioned about myths in the public and misconceptions and lot of misinformation. Unfortunately, that has exists in doctors also.
Yes.
Many of the doctors have misconceptions about diabetic food and don't understand the complexity of the problem. At one extreme, we have got very light approach where doctor thinks it's because of diabetes, I will treat the diabetes and it will heal. And patient also comes with that motion to me. Sir, sugar का थोड़ा हुआ, sugar का इलाज कर दो, मैं पेंसिलिन लिख दो कुछ करो. Once sugar is down, मैं only treatment. It's not that simple. It requires multi-specialty approach to heal. Just controlling sugar is not the treatment of diabetic food. At other extreme, we have got very pessimistic view in many doctors. They say that it's a hopeless thing, nothing can be done. And just go for amputation. They don't know that limbs can be salvaged, limbs can be saved if a multi-specialty team works on it. Many ortho surgeons and many other GPs to whom the patient goes, they discourage the patient. They say there's no point in investing time and money. Just go for amputation and get rid of it. So there is need for education of the patients and more important education of the doctors for handling diabetes food, that it needs a multi-specialty care and it's a curable thing. Food ulcer is a curable thing, and if it is managed, the brain can be saved. As Madam has mentioned, they start with the food ulcer and end up with amputation. In between, there is a window of opportunity where we can stop at the ulcer level and not allow it to go to amputation.
Absolutely true, sir. As Madam has mentioned, it requires a multi-speciality approach, a multi-modality approach, and as Madam has said already, saving a limb is saving a life. This should be kept in mind. Saving a limb is saving a life. So, as this is the progression of the ulcer, starts with the toe, progresses to the forefoot, midfoot, progresses till the ankle, then till the knee. So, a referral in time saves the limb, saves the life, and saves the family. The financial burden is reduced.
Thank you, sir.